Good morning, everyone. I'm going to talk about hemostasis as part of the blood course. As you know, hemostasis is a process of blood clot formation. When we have a vessel injury, and usually abnormal bleeding or thrombosis may occur when specific elements of this process are missing or dysfunctional. As I said with the previous slides, hemostasis is the process of blood clot formation. It's a well-regulated process of blood clot formation at the site of any vessel injury to prevent excessive bleeding. Hemostatic response must be quick, localized, and carefully regulated. When they work in coordinated harmony, a clot is let down initially to stop bleeding, followed by eventual clot lysis and tissue remodeling. Normal hemostatic response to vascular damage depends on a coordinated interaction between blood vessel wall, the endothelium, circulating platelets, coagulation factors, coagulation inhibitors, and elements of the fibrinolytic system. The clotting process is dynamic, including multiple phases and processes, usually start by endothelial injury and formation of the platelet plug, propagation of the clotting process by the coagulation cascade, termination of clotting by antithrombotic control mechanism, and the removal of the clot by fibrinolysis. This cartoon explains better the hemostatic process. We can see that steps 1 and 2 leads to the formation of the primary hemostatic plug through the interaction of the injured vessel wall that leads to its vasoconstriction and the addition of platelets, forming the platelet clump primary hemostasis. And then we can see step 3 and 4. Step 3 and 4 show the formation of fibrin clot through the interaction between aggregated platelets with variable coagulation factors leading to generation of fibrin, which leading to the formation of the secondary hemostatic plug or secondary hemostasis. Finally, step 5 shows the breakdown and removal of the clot fibrinolysis. Another cartoon to simplify the hemostatic process. It's all started by having a blood vessel injury. At the vascular phase, we will see a vascular spasm, excuse me, and then we'll go inside the vessel lumen where we have the platelet plug formation. Usually platelets are activated by chemicals released from the injury site and by contact with underlying collagen. The platelets become spiked and stick to each other at the wound site, creating the platelet aggregation and formating the platelet plug. So you see how I'm focusing on the mechanism of hemostasis or the processes of hemostasis because it's very important to understand how that works. The process of hemostasis can be divided into two distinct stages, namely the primary hemostasis, which is the platelet plug formation, and the secondary hemostasis, which is the coagulation cascade. The goal of both primary and secondary hemostasis is to arrest bleeding from damaged blood vessels. Is counterbalanced by reactions which prevent blood coagulation in uninjured vessels and maintain the blood in a fluid state. It's a balance between procoagulant and anticoagulant. we have four overlapping stages or processes. It starts by a local vasoconstriction. At the same time, we have the platelets activation and the formation of a platelet plug. And we have also the tissue factor release and the introduction of the blood coagulation cascade that lead to fibrin protein formation that penetrate and surround the platelet plug, which we name the blood coagulation or clotting that cause a stable hemostatic plug. And finally, we will see the clot retraction. The primary hemostasis is usually start when platelets adhere to damaged endothelium to form a platelet plug. Platelets usually play one of the biggest roles in the hemostatic process. When it comes across the injured endothelium cells, they change shape. Also, they release granules and ultimately become sticky. Platelets express certain receptors, some of which are used for the adhesion of platelets. So when platelets are activated, they express receptors that interact with other platelets, producing aggregation and adhesion. So they recruit, they cause aggregation, which causes the hemostatic plug or platelet plug. And then we see platelets release cytoplasmic granules such as ADP, adenosine diphosphate, thromboxane A2, and serotonin. ADP attracts more platelets to the affected area. Serotonin is a vasoconstrictor, and thromboxane A2 assists in platelets aggregation, vasoconstriction, and degranulation. More chemicals are released, so more platelets stick and release their chemicals, creating a platelet plug and continuing the process in a positive feedback loop. Platelets alone are responsible for stopping the bleeding of unnoticed wear and tear of our skin on a daily basis. This is referred as a primary hemostasis. Let's now talk about the coagulation cascade, which is the formation of the secondary hemostatic plug. Usually, it's a sequential activation of a series of proenzymes to activate enzymes, resulting in significant stepwise response amplification, leading to secondary hemostatic plug. When we talk about the secondary hemostasis, usually we are talking about local activation of the coagulation cascade, as we can see with this cartoon, where it involves tissue factor and the platelet phospholipids that usually results in fibrin polymerization, which it means it's make like a cementing the platelets into a definitive secondary hemostatic plug. In other words, we can say that blood clotting is the transformation of blood from a liquid soluble fibrinogen into solid gel form and soluble fibrin strands. This fibrin will strengthen the previous platelet plug. The coagulation cascade process occurs via two pathways which unite downstream to form the common pathway. These are the, let me put the pointer, that includes the extrinsic pathway, usually triggered by external trauma, which causes blood to escape the circulation, and the intrinsic pathway, usually triggered by internal damage to the vessel wall. And usually it includes the following factors which are listed here. Usually the extrinsic pathway start by a damage to the blood vessel, means that factor 7 exits the circulation into surrounding tissues. The tissue factor, which is a factor number 3, is released by damaged cells outside the circulation caused by trauma. The complex factor 7A and factor 3 usually lead to activation of factor 10 in conjunction with factor 5A. Factor 10A usually triggers the formation of thrombin. Finally, the extrinsic pathway is responsible for the initial generation of activated factor 10, where the intrinsic pathway amplifies its production. The intrinsic pathway of coagulation is the longer and more intricate pathway. Factor 12 usually activated once it comes in contact with negatively charged collagen on the damaged endothelium, damaged surface, triggering the cascade as detailed here. Along with the clotting factors, platelets form a cellular plaque, as we talked initially at the site of injury. These platelets also release mediators that facilitate further clotting, including factor 8 as we see here. Factor 9 combines with factor 8 to form an enzyme complex that activated factor 10. Factor 10 plus factor 5A stimulates the production of more thrombin. This table summarizes the coagulation factors, and you can mnemonic to remember the clotting factors by saying foolish people try climbing long slopes after Christmas. Some people have fallen. So the first letter of each word corresponds to each of the clotting factors sequentially. Back to the coagulation cascade, as we said previously, a series of biochemical reactions leading to the formation of a blood clot, the formation of prothrombin activator complex by extrinsic and intrinsic pathway, leading to the activation of the common pathway as we see here. This reaction leads to the activation of thrombin enzymes, clotting factor 2 into thrombin. So the prothrombin, which is inactive thrombin, is activated by a long intrinsic and short extrinsic pathways. The thrombin will change fibrinogen, as we see, a thrombin will change fibrinogen, a plasma protein, to fibrin and soluble protein. And usually the conversion of fibrinogen into fibrin leads to stable fibrin polymer. So it's another way to explain what's going on when we have a trauma or injury or release of tissue factor, activation of the intrinsic pathway by contact with collagen, and then we can see the prothrombin activator complex that usually lead to the activation of the common pathway, and for that you need those cofactors to activate the common extrinsic pathway, and all lead to stable fibrin polymer, and of course you need the fibrin stabilizing factor 8 to lead to that step. So this one is a completion of the previous slides. The next couple of slides also explain what we already discussed earlier during that presentation. Just I'm really repeating because I know it's a very difficult topic and it's very important to follow steps to understand how the coagulation cascade function. So as you can see here, that explain for extrinsic one. These slides also give you an overview about the intrinsic pathway, about the common pathway. In these slides, we can see the coagulation cascade and the related coagulation test. As we can see here, like the APTT is usually used to measure intrinsic pathway, the PT or prothrombin time, usually for extrinsic pathway. Just for your information, usually PT often elevated when we have vitamin K deficiency or antagonism, like medication, anti-vitamin K like warfarin, factor 7 deficiency or inhibitor, or when we have a liver disease. APTT usually elevated when we have when we are using anticoagulation like heparin, or if you have deficiency or inhibitor of factor 11, 9, and 8. And we can see both tests elevated in DIC or factor 10, 5, 2, or fibrinogen deficiency or inhibitor. You can use this cartoon as an extra material if you still have any question concerning the coagulation cascade and the progress or the process of blood clotting formation. So again, just really to consolidate your knowledge, PT evaluates extrinsic pathway that start with interaction between tissue factor, extrinsic, and factor 7. APTT is usually used to assess the intrinsic pathway. Again, intrinsic pathway, here we are talking about factors 12, 11, 9, and 8, which similar to end result from activation of the extrinsic pathway and in the activation of the common pathway at factor 10 and 5. Coagulation is really complicated, and many times we are really, as a teacher, enthusiastic about the topic, which is good. However, when we try to tell you everything we know, usually it became too complicated. So to make it a bit easier, we are using a simple learning tricks like mnemonics, as we can see in the slides and the next slide. Again, you can see it's another way to learn coagulation factor and the intrinsic pathway. It's a mnemonics of first letters. It's maybe something easier to remember. The PT and the PTT pathway meet at factor 10 because 10 is the common pathway. Also, factor 5 is a cofactor for factor 10, and you can remember this because 5 fits into the notch of the 10. It's another way really try to like give you some hints how to remember and memorize the coagulation cascade. And as I said before, it's really something difficult and hard as a topic. These slides also maybe will help you that factor 10A with factor 5A as a cofactors converts prothrombin, which is factor 2 into thrombin, which is a very important in the coagulation cascade. We can also see here that thrombin, among other things, converts the soluble molecule fibrinogen into a solid fibrin clot, fibrin. Thrombin has several important functions in the coagulation cascade that are not limited to formation of fibrin, as you can see in the slides. However, it's a key coagulant enzyme converting soluble fibrinogen to insoluble fibrous fibrin. It also induces further platelets recruitment and granule release and activates the coagulation pathway. And now we are going to address the final step of the hemostasis to prevent excessive clotting, the clot elimination and fibrinolysis. The role of this anticoagulant is to prevent excessive clotting after preventing excessive bleeding. Any break of the balance between procoagulant and anticoagulant would lead either to excessive bleeding or excessive clotting, depending on where the abnormality occurs. As a natural anticoagulant, we have a protein C, protein S as coenzyme for protein C, and protein C plus thrombomodulin. It usually inhibits factor 5 and factor 8, and in this way affecting intrinsic pathway. The antithrombin has a direct inhibitor of thrombin, and you have the tissue factor pathway inhibitors that stops the extrinsic pathway. It's another slide to explain the same idea. An excessive clotting would cause thrombosis, and excessive fibrinolysis will cause bleeding. Formed blood clot can either become fibrous or dissolve. Fibrinolysis means dissolving. It's a breakdown of fibrin by naturally occurring enzyme plasmin. Therefore prevent intravascular blocking. There is balance between clotting and fibrinolysis, and here we show the fibrinolytic pathway and its inhibitors, the antiplasmin as we can see here, and the plasminogen activator inhibitor PAI. Fibrinolysis includes removal of the formed clot by the proteolytic enzyme plasmin to restore vessel patency following hemostasis. Plasminogen is converted to plasmin following the release of tissue plasminogen activator TPA from endothelial cells. Plasminogen binds TPA to fibrin. This complex leads to conversion of the proenzyme plasminogen to activate proteolytic plasmin. Plasmin limits the extent of the evolving thrombus. Hemostasis is a well-balanced process between the clot initiation and formation and fibrinolysis, as can explain that cartoon. In the slides we can see the control mechanism and termination of clotting, and also we can see inhibitory molecules at different steps of the coagulation cascade. And you can see also the activator and inhibitors on the slides concerning the coagulation cascade. Any disruption of this unique balance may cause bleeding or thrombosis. This part we are going to focus on tests of hemostatic function. Defective hemostasis with abnormal bleeding may result from, it could be vascular disorder, it could be thrombocytopenia or platelet dysfunction, it could be defective blood coagulation. We have a number of tests are used to assess the platelet, vessel wall, and coagulation components of hemostasis. We have a few tests that we use to measure hemostatic function, starting by platelet count and the blood film examination used to evaluate primary hemostasis, which depends on number and function of platelets, and also we can use bleeding time to evaluate platelet function. The prothrombin time, or PT, measures factor 7, 10, and 5. Prothrombin and fibrinogen, and usually normal is between 10 and 14 seconds, and usually also used to evaluate the extrinsic pathway. The international normalized ratio or PT ratio ENR, usually used to standardize PT results and to ensure that results from a PT test are the same from one lab to another. Prothrombin time or PT is a blood test that measures how long it takes blood to clot, or you can say the time to form a fibrin clot after addition of thromboplastin, a tissue factor combined with phospholipid and calcium to citrated plasma. How we measure prothrombin time is a method. Usually you put a platelet poor plasma, PPP, plus is usually mixed with tissue factor containing phospholipid and incubated at 37 degrees, and an excess of calcium chloride is added to initiate coagulation. The time taken from the addition of calcium to the formation of the fibrin clot is known as the prothrombin time or PT. Activated partial thromboplastin time or APTT measures factors 8, 9, 11 and 12 in addition to factors 10, 5, prothrombin and fibrinogen, and the normal is between 30 and 40 seconds, usually used to evaluate the intrinsic pathway. APTT is a two-step assay to measure time to form a fibrin clot after incubation of citrated plasma with phospholipids negatively charged, and the negative surface and phospholipids activate contact factors and factor 11. Calcium activates factor 9 and remaining cascade to form the fibrin clot. When we say calcium, it means the calcium chloride. Now we are going to talk about the methodology for testing APTT. A platelet poor plasma is incubated at 37 degrees, then phospholipid and a contact activator like selite or silica or kaolin are added. This leads to the conversion of factor 11 to factor 11A, but the remainder of the pathway is not activated as no calcium is present. The addition of calcium pre-warmed to 37 degrees initiates clotting and the timer is started, the clotting time. The APTT is the time taken from the addition of calcium to the formation of a fibrin clot. Thrombin or clotting time is sensitive to when fibrinogen levels are low or inhibition of thrombin, which is usually normal between 14 and 16 seconds. It's usually widely used, also not necessarily part of the basic screening profile. It reflects the conversion of fibrinogen to fibrin, but it's also used, also sensitive to the presence of inhibitors that may be present in the plasma like heparin. And the methodology, usually human thrombin, is added to platelet poor plasma at 37 degrees, and the time taken for the formation of fibrin clot recorded, and recalcification of the plasma in this case is not necessarily. We are going to talk about abnormal coagulation test. For example, if prolonged PT-ENR with normal PTT, think about factor 7 abnormality or deficiency, because as we know, this as PT evaluates the extrinsic pathway. Deficiencies of factors 12, 11, 9, 8 will prolong the PTT and not the PT. Remember that factor 10 is in the common pathway, and thus its deficiency would affect both PT and PTT. It means if you have any abnormality concerning factor 10, you will see prolongation of PT and PTT. 12, 11, 9, 8, it will prolong PTT, the intrinsic pathway, and not the PT. These factors are in the common pathway, factor 5, 10, prothrombin, or factor 2 and fibrinogen, and in this case we see prolongation of PT and APTT. I hope you will find this part more exciting. We are talking now about abnormalities. So when we talk about abnormalities of the coagulation cascade, we have either a hypercoagulability state or bleeding diathesis. A blood clotting disorder makes your blood form clots too easily, and in this case we call it hypercoagulable state or thrombophilia. However, a bleeding diathesis refers to the increased tendency to bleed or bruise. It might be a result from acquired or congenital causes, most of which result in an impaired clotting process. Let's talk about bleeding disorder. To evaluate a patient with bleeding disorder, you need to have a careful history and physical exam. You need to check family history for any bleeding disorder. As I said, it could be acquired bleeding disorder or congenital causes. We need to check previous surgeries and need for blood transfusion. We need to check history of excessive bleeding post any trauma or delayed wound healing, and also to check for easy bruising. Patients with normal PT and PTT but history suggestive of bleeding disorder, we have to think about platelet disorders. Check it by bleeding time, as von Willebrand disease, Bernard-Soulier, Glanzmann thrombasthenia, and also we have to keep in mind the possibility of factor 13 deficiency. Bernard-Soulier and Glanzmann thrombasthenia are inherited platelet disorder. Von Willebrand disease has qualitative and quantitative deficiency of von Willebrand factor. Also, it's very important to know Bernard-Soulier syndrome is a rare inherited blood clotting disorder characterized by unusually giant platelet cells, thrombocytopenia, and prolonged bleeding time. Usually affected individuals tend to bleed excessively and incur spontaneous ecchymosis. As I said, it's inherited blood platelet disorders, and just for you to know, usually a result of genetic mutation encoding for one of three genes, GP1BA, GP1BB, and GP9. Von Willebrand disease is the most common bleeding disorder. It's usually around 1% of the US population. It occurs among men and women equally, and women are more likely to notice the symptoms because of the heavy or abnormal bleeding during their menstrual periods, and usually affect childbirth. There is different types of von Willebrand disease, and as we said before, it's a blood disorder in which the blood does not clot properly. Blood contains many proteins that help the blood clot when needed. One of these proteins is called von Willebrand factor. People with von Willebrand disease either have a low level of von Willebrand factor in their blood, or the von Willebrand factor protein doesn't work the way it should. And finally, Glanzmann thrombasthenia. It's a rare platelet disorder in which the platelets have qualitative or quantitative deficiencies of the fibrinogen receptor. Most cases are hereditary, inherited in an autosomal recessive pattern, but acquired Glanzman thrombocythemia also occurs. Most symptoms or signs are mucosal bleeding, gingival bleeding, petechia, ecchymosis, menorrhagia, and gastrointestinal bleeding. We can see normal PT and prolonged PTT in inherited disease as factor deficiency 8, 9, 11, and 12, and in von Willebrand disease when von Willebrand factors carries factor 8, acquired when we use heparin or with lipase anticoagulant, and also when we use inhibitors to factor 8, 9, 11, or 12. So to differentiate between factor deficiency and factor inhibitor, we do mixing studies. Mixing studies in factor deficiency, when we mix the patient's blood with that from a normal individual, PTT corrects. While in the presence of inhibitors, mixing studies do not show correction of PTT or incomplete correction. Just keep in mind, with lipase anticoagulant, PTT is prolonged, test related, but actually patients are at risk of clotting and not bleeding. Among the bleeding disorders, hemophilia is related to deficiency of either factor 8 or factor 9. Male usually are X-linked recessive disease, male children of carrier females. Symptoms: bleeding from impaired hemostasis, prolonged bleeding after trauma, bleeding from small cuts is uncommon, hemarthrosis or bleeding into joints is the most common site of bleeding, and that you have to keep it in mind. As a late complications of hemophilia, we can see hemophilic arthropathy or infection from plasma-derived products or development of inhibitors. The last two are related to the fact that patients need recurrent administration of the deficient factor to treat or prevent excessive bleeding, and that causes the development of inhibitors and possible infection. In hemophilia, we can see prolonged APTT, as we are talking about factor 8 or 9 deficiency. PT is not affected, so we have a normal PT, and if we use mixing studies, usually APTT corrects with mixing study because we have factor deficiency and not inhibitors. So just to explain a little bit more, since it's caused by deficiency of the factor, APTT corrects on mixing studies, and that part is very important. Sometimes patients can develop inhibitors to factors due to repeated administration of the deficient factor, and then would not have complete correction on mixing study. Just keep in mind, it's one of the late complications of hemophilia. In this one, we can see acute hemarthrosis of the left knee in patients with hemophilia A. Also, you can see severe disability as a late complication of hemophilia, or a massive hemorrhage in the area of the right buttock. Now let's talk about bleeding disorder with prolonged PT and normal PTT. Inherited, we can talk about factor 7 deficiency. Acquired, you have vitamin K deficiency, liver disease, and also drug-induced like warfarin administration. Keep in mind that the liver is responsible for synthesis of most of the procoagulant as well as anticoagulant factors. Thus, liver disease can be associated with bleeding disorders. Vitamin K has a major role in coagulation pathways. It's important for the production of several procoagulant factors, as well as some of the anticoagulant protein. It plays a role as a cofactor in the synthesis of clotting factors 2, 7, 9, and 10. It's necessary for synthesis of anticoagulation protein C and S, also necessary for formation of other protein. Causes of vitamin K deficiency could be fat malabsorption, prolonged use of broad-spectrum antibiotics, TPN without vitamin K supplementation, and also lack of oral intake. As a lab findings, we can see abnormal findings with prolonged PT or PTT, also decreased level of factor 2, 7, 9, and 10. And it's associated with normal bleeding time, fibrinogen, platelets, and other coagulation factors as factor 5 and 8. Vitamin K antagonists are drugs used for anticoagulation, and usually it's as a coumarin-like family. Coumarin-like anticoagulants are similar in structure to vitamin K, warfarin, coumadin as example, and usually interrupt the vitamin K dependent carboxylation cycle. And we use vitamin K is one of the methods used to reverse the effects of coumarin when we have excessive use or bleeding. Now we are going to talk about the category of bleeding disorders with prolonged PT and PTT. We can see that in deficiency of prothrombin, fibrinogen, or factors 5 and 10. We can see that in liver disease affecting factor 2, 7, 9, and 10. We can see it in coagulopathy leading to consumption of factors, clotting factors like DIC, and finally it could be drug induced like combined heparin and warfarin administration. Disseminated intravascular coagulation or DIC is a rare but serious condition that causes abnormal blood clotting throughout the body's blood vessels. We might develop DIC if you have an infection or injury that affects the body's normal blood clotting process. It leads to compromise of tissue blood flow and can ultimately lead to multiple organ damage, as the coagulation process consumes clotting factors and platelets. Normal clotting is disrupted and severe bleeding can occur from various sites. DIC can complicate several conditions and is generally associated with high risk for mortality. These slides, it helps you to understand DIC pathophysiology. It's a reminder of what we have previously discussed regarding the normal hemostatic process to help explain the pathophysiology of DIC. In DIC, the processes of coagulation and fibrinolysis are dysregulated, and the result is widespread clotting with resultant bleeding. One critical mediator of DIC is the release of tissue factor. Tissue factor produced under various conditions like infection, sepsis, trauma, major surgery, malignancy. TF activates the coagulation cascade with thrombin surge forming small clots, and you can see after that we can see small clots harbor more platelets, activate more the cascade, occlusion of vessels, bleeding and clotting. It usually causes multi-organ failure, and usually mortality are very high with DIC if we don't treat the cause of DIC. What findings do you expect with DIC? Let's see the next slides. With the DIC lab findings are well summarized here. Prolongation of PT and APTT, low fibrinogen level, low platelet counts, high level of fibrinogen degradation products, and peripheral blood smear may show schistocytes. I have two questions in these slides just to raise your awareness about the required test in different clinical scenario. As we can see, PT is the best test to assess extrinsic pathway and warfarin, and also APTT is the best test to assess heparin effect. This slide is to review mixing studies with the various conditions we discussed so far. For example, if you mix patient plasma with normal plasma, what would happen if the patient has liver disease? Usually correct. Taking Coumadin, it corrects. Taking heparin, corrects. Has lipase anticoagulant inhibitor? No, because we have inhibitor. Factor VIII inhibitor, no correction because there is inhibitor. Let's move to the last part of the presentation by talking about hypercoagulability. Keep in mind that some conditions can be associated with both risk of bleeding as well as risk for clotting, like DIC, liver disease, and many other coagulation disorder. The abnormality of the hemostasis pathway can also include excessive coagulation, as we referred here about hypercoagulability states. Inherited disorder, we can talk about factor V Leiden is a mutation of one of the clotting factors in the blood. As this mutation can increase your chance of developing abnormal blood clots, most commonly in your legs or lungs. Most people with factor V Leiden never develop abnormal clots, but in people who do, this abnormal clots can lead to long-term health problems or become a life-threatening abnormality. Women who carry the factor V Leiden mutation may have an increased tendency to develop blood clots during pregnancy or when taking the hormone estrogen. Other clotting disorder we can have prothrombin gene mutation, protein S deficiency, protein C deficiency, antithrombin deficiency, or dysfibrinogenemia. One or two slides. Take-home messages. Normal hemostasis requires vasoconstriction, platelet aggregation, which is the primary hemostasis, and the blood coagulation via activation of coagulation pathways, the secondary hemostasis. Blood coagulation in response to vascular injury starts with tissue factor binding to clotting factor 7, and this initiates a cascade which results in thrombin generation. Thrombin then activates factor 8 and factor 5 and factor 11, which greatly amplifies the coagulation pathway, resulting in a fibrin clot. Coagulation factor inhibitors include antithrombin, protein C, and protein S. There should be a balance between coagulation and anticoagulation. Dissolution of fibrin clots, fibrinolysis, occurs by activation of plasminogen to plasmin. Testing for bleeding include assays to assess platelet number and function, but also assays to assess coagulation factor numbers and function, PT, APTT, and mixing studies. Thank you for your attention. If you have any question, please email me, and I promise to answer as soon as I can, and we will see you soon during our TBL session. Good luck.